Hello, my name is Choi from Joongwon University, Gwangmyeong Hospital. Now I would like to introduce the paper published in Investigative and Clinical Urology this month, and I'm the first author. The title of the paper is slightly long and is Comparative Analysis of Recurrence Rate between intravesical gemcitabine and BCG induction therapy following transurethral resection of bladder tumors in patients with intermediate and high-risk bladder cancer, a retrospective multicenter study. Currently, transurethral resection of bladder tumor following by intravesical therapy with BCG is gold standard treatment in intermediate or high-risk patient cohort by AUA guideline. But as you know, there are global shortage of BCG since 2016, and it's now ongoing status in Korea. So in this study, we try to investigate the efficacy of intravesical gemcitabine as an alternative treatment to BCG in the intermediate and high-risk population, especially for the first year. This study was initiated as a research project by the Bladder Cancer Study Group of Korean Urological Oncology Society, participated from 7 institutions. And in Korea, intravesical gemcitabine is covered by insurance in this kind of patients since 2022. Retrospective data collection was conducted from February 1999 to May 2023. Patient included in the study was who underwent TURBT following an initial diagnosis of bladder tumor and categorized as intermediate and high risk according to AUA risk classification. And the selection criteria encompassed patients who had undergone at least 4 sessions of therapy and followed up more than 3 months after treatment. Data assessment was conducted in a cohort of 149 patients who underwent initial TURBT and intravesical therapy. Among these patients, 63 received intravesical gemcitabine and 86 patients received BCG induction therapy. The baseline characteristics of 2 groups demonstrated no significant differences, but there was a significant differences in the follow-up duration, maybe due to insurance coverage in Korea. And there are more than 60% of high-risk patients in both groups. Details of intravesical therapy and its side effects are presented in this table. Induction therapy was administered in 6 sessions for more than 90% of patients in both groups, and maintenance therapy was more frequently administered in the gemcitabine group with 73% versus 8%. During the intravesical therapy, the adverse event occurrence was similar between the 2 groups with about 22%, but there was more than 15% of grade 2 Clavian Dindo side effects occurred in BCG group. The treatment outcomes are in this table. There are significant differences in any recur patient, maybe due to follow-up differences. So we compare the recurrence rate for each time period with 3 months, 6 months, and 1 year recurrence rate. You will see the figure in the next page. There are no significant differences in first recurrence data except this stage. This is 1 year treatment outcome data. The 3-month CR rate were comparable between the gemcitabine and BCG groups with 98% versus 95%. And there was constant, no significant differences in 6 months and 1 year CR rate, and it's about 94% to 84%. And disease progression was defined as an increasing T stage, increasing grade, or occurrence of CIS. You can see no statistically significant differences in the rate of progression-free survival between the gemcitabine and BCG groups. In conclusion, intravesical gemcitabine showed similar efficacy to that of BCG as an induction therapy in patients with intermediate and high-risk non-muscle invasive bladder cancer patients for the first year. And the occurrence rate of adverse events were comparable between two groups, but in gemcitabine group there was more mild adverse event was observed. Thank you for attention.